welcome group to our weekly Lunch and Learn. We have a great program for you today, so we really do appreciate the opportunity that you will have today, and hopefully that it will be very beneficial to you and your board. So once again, I am Gary Sechrist with KASB Leadership. As we always have is a KSB legal representative, Sam Blasi. So Sam will be at the ready if there happens to be any legal questions based upon our topic today. Dr. Britton Hart is with us, and he will be helping us with some of the technology. We also have some other KSB folks who are working in the background just in case they're needed. So next slide, Dr. Hart. So with that, I am very, very pleased to welcome the Kansas COVID Work Group for Kids. We have a great representative sample of doctors who are within that work group who are with us today. The doctors that we know are with us are Dr. Stephanie Kuhlman, Dr. Gretchen Homan, Dr. Kristen Darnauer, Dr. Carrie Harris, Dr. Amy Seary, Dr. Farah Ahmed, and Dr. Kelly Netson. So with that said, we've got a lot of information that we are going to be covering. So I'm going to hand it off to Dr. Kuhlman. As usual, if you have any questions, please put them in the chat. We are going to do something a little different. Some of the physicians that are with us, they may be able to answer some of your questions on chat. The formal opportunity to answer your questions verbally will be more at the conclusion of this presentation, but that does not negate you asking any questions in the meantime. So we'll try to call those up if they're not answered by any of the physicians with us. So Dr. Kuhlman, thank you so much for your group being here, and I'm going to hand it off to you.
All right, thank you. Thank you for allowing us to be here. Can you hear me okay?
Yes.
A lot of feedback. Sorry. Thank you for allowing us to speak to you guys today. As school administrators and Board of Education members, you guys certainly have a very, very important job right now, and a very busy job. So I appreciate you guys taking time out of your day to join us and working to get our kids safely back into school. I'm the facilitator of the Kansas COVID Work Group for Kids. This group was initiated to really focus on the physical, social, and emotional needs of kids as a result of the pandemic. And we are sponsored by the KU School of Medicine, Wichita Department of Pediatrics. We've been endorsed by the Kansas chapter of the American Academy of Pediatrics and the Family Academy of, the Kansas Academy of the Family Physicians. Our group really is a kind of an ad hoc, non-political group of physician representation across the state. We also have psychologists as well as school counselors and school nurses on our team. You can see our team members. These slides will be available. I hope that you guys can have to kind of see who is on our team. Present today are the doctors that Gary just introduced us to. We do have kind of good representation here of Dr. Harris is an adolescent physician, Dr. Homan's an outpatient, Dr. Darnauer is in a smaller community, Dr. Seary and myself are at the various hospitals in Wichita, and Dr. Nutson's a psychologist, and Dr. Ahmed's the state epidemiologist. So we feel like we have a good variety for you guys today, and I think that'll help as you guys do have questions. We can kind of give different perspectives and insights based on our group. Our goals today are to look at the effect on children related to the SARS-CoV virus, and then also we really want to spend time is looking at how to use the KSDE gating criteria that came out and was released, as we hope that you guys may be able to make some decisions related to school modes of learning and opening based on that criteria. And then we have some considerations on other things that may make school opening successful, based, again, just on our opinions and perspectives. And then we do hope to have some time to answer questions for you guys. So I'm going to turn it over to Dr. Darnauer. There'll be three physicians or three doctors that will speak today on various topics. We'll kind of run through our slides and then hopefully have more time for discussion and question and answer time.
Thanks, Stephanie. Can you hear me?
Mm-hmm.
I'm Christy Darnauer. I'm a family practice physician in Sterling, Kansas, which is Rice County, right in the middle of the state. And I have 3 kids in public school, so that's my other investment here, right? I'm just going to briefly talk about the statistics related to COVID-19 in children, and many of these things you probably already know. I won't spend a lot of time on them. In general, children have been fairly unaffected by COVID-19 compared to adults. Only 9% of all of our confirmed COVID cases are in children, whereas they represent about 23% of our population. But in the last 2 weeks, we have seen quite an increase in our case numbers, up 24% in the last 2 weeks alone. We think the low numbers among children may be related to the fact that we closed down schools and we have kept children largely apart from the general public and from each other. So we anticipate that number to increase over time. But it does seem that COVID-19 is a better disease in children. It does not cause the same morbidity and mortality. So our hospitalization rates are lower and our death rates are lower. We've had 90 deaths so far in the US from COVID-19 at this point. These are the numbers as we look at them in the state of Kansas, and you can see just the case rates as they appear here on this slide. 3% in the 0 to 9 range, and 10 to 18-year-olds, it's about 6%. We've had 35 hospitalizations among kids, and we have had 2 deaths, and they're in the 18 to 24 age. So that's fairly noteworthy, again, that hospitalization and death rate is quite a bit lower. You can see the few clusters we've had, which are easily accessed on KDHE's website, but school and daycare outbreaks, there's been 16 clusters so far, and sports-related clusters, we've had 9 that relate, again, to the pediatric population. So again, children in general are less likely to be infected, and then when they're affected and infected, they have mild to no symptoms. And very few of them, thankfully, become severely ill with COVID-19. Younger kids seem to transmit it less frequently than older adults, or than older children and adults. We really treat adolescents fairly similarly to adults in this, in that it does seem like they transmit it more readily. And household contacts, of course, are going to be the highest risk of transmission when it relates to children and adults interacting. That household contact is a big piece of that. We have looked, as we are making recommendations as a group, we have looked a lot at other countries and the things that they have done. And we were optimistic seeing other countries opening schools. Most of the time, the success is related to the success of the community transmission rates. Often they are lower transmission rates, they have good testing and contact tracing available. And you'll hear this theme throughout our conversation, that the success of the community will really guide the success of the school reopening. Safety measures do reduce transmission, but because students and staff are going home and interacting with more people, and they're bringing it back to the school, we really have to have a community approach. Universal safety measures, again, are critical in that. Communities have to take responsibility. We'll just keep saying that over and over again because we feel the safety of our students and our staff and our teachers and their families should be a priority, and that education and the social structures that school provide are just worth all the sacrifices that we have to make as a community. So I'll get off the soapbox. Schools need to reopen. That is our big push. We, from the beginning, have been very concerned about our students being out of school and what that meant for them socially, emotionally, from nutritionally. I have a private practice here in Sterling, and I have seen the COVID weight gain even among my pediatric patients from inactivity, from poor nutrition. So they need school from a physical standpoint as well. It ensures a safe environment, again, for the rest of our world to work. It's used for childcare for parents to be able to get back into work and into the economy. I don't have to tell this to you guys, I'm preaching to the choir. But we do also have to think about some of our most vulnerable students as well. Children with special health care needs are often those needs are met through our school systems. Special education and learning needs, of course, and then the social disparities. We talk a lot about school lunch, but we know it goes farther than that as well. So I'm just this is just one brief intro slide to then hand off to Dr. Ahmed. Gating criteria, I'm sure that you are familiar with that terminology by this point. It is the use of metrics, data, and benchmarks to help determine school reopening, but also as we move down the road, it will affect school closure and then reopening again. So they're metrics that are designed to be used throughout the whole process. It's been a collaborative effort between multiple organizations here in our state at least, and I know many local health departments have been involved with local school boards for these same concepts. It has been developed, at least in our realm with our group, after thoughtful consideration and discussion of similar documents that other states are using, as well as lots of data, as much as we can get our hands on. It's coming out every week as we're learning more and more and seeing more studies available to us, but we're using all of that to guide our decisions and to guide our recommendations. And the idea is that we can use these to help each county, each community, in each school make these hard decisions. And with that, I will pass the torch to Dr. Ahmed.
Great, thank you. So thank you to the Association of School Boards for the opportunity to present some data to support the Kansas school gating criteria. Next slide. So this is the document we've been talking about, which lays out that Kansas school gating criteria that was released recently. So this guidance, and it is guidance, it's not mandate, but it was released with the support of the Kansas Department of Education and KDHE. I've included the link here so you can find that through the link. Next slide. So KDHE is working to provide the data for each of these metrics so that local health departments and school districts can make decisions about school reopening. Next slide. So to actually get to the data for the school gating metrics, you go to the KDHE website. So I've boxed that in red at the top. And then you click on the banner for COVID-19, and that's where the red arrow is pointing. Next slide. So then you click on the COVID-19 cases in Kansas. So that's where we put all of our data. And just as a plug for our site, we do have a lot of data up there, including data on hospital capacity and demographics of cases, as well as information on clusters. Next slide. So each of these tabs is going to take you to a different data visualization, but for today's discussion, we're going to want to click on that tab for school gating metrics. That's where that red arrow is pointing. Next slide. So if you click on the school gating metrics, it's going to take you to a landing page with some description of the metrics. So far, we've posted data for the trend in incidence rate and the 2-week % positive case rate. And then the data to get the 2-week cumulative incidence rate is also available. That's just within the trend in incidence rate table. Right now, it just takes some very minor calculation on your part, so I'll kind of go through that. So after the description, there's going to be a series of tabs for the different metrics. So we're going to look at the trend in incidence rate first. Next slide. So in the school gating criteria document, it's the metric that's boxed in red here. Next slide. So if you click on that trend in incidence rate tab, it's going to take you to a table that looks like this. So incidence rate is defined as the number of new cases by symptom onset date in a week's period per 100,000 population. So what we mean by symptom onset date is that's the date that a case started having symptoms. And if it's an asymptomatic case, then we count it as the date that their sample was taken. So the arrows indicate whether that trend in incidence rate has increased, decreased, or stayed the same from the week prior. So just note here that we've replaced the green category with blue to indicate decreasing and gray for stable. Otherwise, it matches up exactly with the school gating metrics, but we changed the colors because it was the whole magic eye waiting for something to pop out kind of thing, and it wasn't ADA compliant either. But other than that, it does match up. So we've provided the trends for the state as a whole and broken down by age groups as well. So for example, you can see that the incidence rate going from the week that began July 26th to the week that began August 2nd has a red arrow. So you should be looking at that red arrow for August 2nd, which I've circled. So that indicates that that trend between the 2 weeks was increasing. So then the incidence rate going from the week beginning August 2nd to the week beginning August 9th also has a red arrow. So that indicates that that trend continued to increase. So we've provided the data broken down by age groups in case this helps local health officials and school officials make decisions specific to elementary, middle school, and high school age children, as well as taking into account the age of their staff. Next slide. Next slide. Yeah. So similarly, we've provided the trends by county. So if you just scroll down on the same page, you'll see it broken down by county. Next slide. And by age groups within the county if you scroll down further. So if there's a missing arrow, that indicates that there was no data for that category. Next slide. So the second metric is the 2-week cumulative incidence rate. So the 2-week cumulative incidence rate is defined as the number of new cases for a 2-week period per 100,000 population. So on the school gating criteria, it's the metric that's boxed in here. Next slide. So you can use, wait, 1 second. I might have boxed in the wrong one. I apologize. So you can use the same data for the trend and incidence rate table. So if you hover over the week that began on August 2nd, for example, you can see that we had 87 new cases per 100,000 for that week. Then if you hover over the next week that began August 9th, you can see that we had 102.2 new cases per 100,000 for that week. So you add them up, you take the 87 plus the 102.2, and you got 189.2 new cases per 100,000 for that 2-week period that started on August 2nd and ended on August 15th. Next slide. So my 2-week cumulative incidence rate, again, is that 189.2 new cases per 100,000, and that puts me in the red category according to the gating criteria. Next slide. So we can look at the same thing for a county. So as an example, I just chose Johnson County. So again, you're looking at that same data from that trend and incidence rate table, but you're going to use either use a drop-down menu to pick out Johnson County, or you can just scroll through and find it in the table, however you want to do it. So if you hover on the week that began August 2nd, you can see that Johnson County had 98 new cases per 100,000 that week. Then if you hover over the next week beginning August 9th, you can see that there were 100 new cases per 100,000 for that week. So then you add them up, and then you have 198 new cases per 100,000 in a 2-week period, again, that started August 2nd and ended August 15th. Next slide. So your 2-week cumulative incidence rate of 198 puts you at, or puts Johnson County in a red category according to the gating criteria. Next slide. So the next metric up is the 2-week percent positive case rate, or as we've been calling it all along, we've been calling it the percent positivity. Next slide. So from that school gating metrics landing page, you're going to click on the 2-week % positive case rate. That's where that red arrow is pointing. Next slide. Can you go back one? Yeah, there you go. So we do get a lot of questions about how we calculate % positivity because some local health departments are using a slightly different formula, which normally would have been fine because they're looking to answer a different question. But of course, now that the % positivity is part of the school gating metrics, it becomes a big deal. So my advice is that just the best thing to do is understand any differences if there are any and know what metric you're looking at. So for the school gating metrics, we've used the same formula. KDHE has used the same formula for % positive that we've always used. It's always been available on our dashboard. So we based our original formula on a description of % positivity from CDC. So that's that screenshot that I have there. So on our dashboard, under the, if you've ever looked under the testing rates tab, you can see state level and county level % positivity, but we've been reporting it all along on a daily basis. But for the school metrics, we wanted to go ahead and look at that on a weekly basis. So the KDHE formula for % positive is the number of positive PCR tests for that week, and that is based on a laboratory test date, and that's divided by the total number of positive and negative PCR tests for that same week. So we do exclude test results that are indeterminate or inconclusive. That means that the instrumentation at the lab just couldn't give you a positive or a negative result. So we feel like that's pretty close to the CDC definition. Next slide. So the data is available, again, at the state level overall, and it's broken down by age group. So for example, if there's a blue dot on June 7th, that shows that the state was at a % positivity for that week below 5%. So again, that's the week that started June 7th, we're at below 5%. Then for the week that started on June 14th, we're at a yellow dot, which means that we're between 5% but less than 10%. So my understanding is if you're looking at 2 different colors for a 2-week period, you would choose the color dot that represents the higher risk category. So in this case, if I'm just focusing in on these 2 weeks, I would pick the risk category associated with the yellow dot. And again, for us, we put blue dots in place of green for the same reason that I explained earlier. Next slide. So we've provided the same data by county and you can stay on this slide, and by age groups within the county in case, again, that helps you make more specific decisions for your elementary or your middle and high school. Next slide. So again, if you want to look at a specific county, for example, Johnson County, you would just hover over the week that began August 2nd. For example, you can see for that week there was a % positivity of 7%, and then if you hover over the week beginning August 9th, you can see that there was a % positivity of 8.29% for that week. So for that 2-week period, both weeks are in the yellow category. Again, my understanding is if they had been 2 different color dots, you would go with the higher risk category. Next slide. All right. And then the final metric I'll talk about today is student absenteeism. Next slide. Yeah. So KDHE did create a Qualtrics survey that went out from the Kansas Board of Education to schools. The survey is collecting information on student and staff absenteeism, and our plan is to share that data back on our dashboard, but by county. So that means we're not going to be identifying individual schools on the public dashboard, but we will share, and we have already shared the first week of data identified at the school level back with the local health department who can share it with you. So if you are interested in your school level data for your district, please ask your local health department. That data is going to be sent weekly as a spreadsheet to the local health department administrators. So last Friday was the first date of reporting, and Monday we sent out the first spreadsheet to the administrators. So just a few FAQs about the survey because we do get a lot of questions. So absenteeism is how the school or the school district normally defines absent for students and staff. So that clarifying language has been put into the survey. Because the whole point is to compare where you are now compared to what your normal baseline is, we didn't try to define absent. It is whatever that school or the school district defines as absent. Schools should begin reporting even if they're not in session and even if they're virtual only. There are options on that survey to indicate that the school hasn't started yet and to indicate what learning environment the school is in. In addition to collecting information about what learning environment the school is in, we're also collecting information on the mask usage policy week to week. So as we get more data in, we'll hopefully be able to track, okay, what's going on with the mask usage policy, what's going on with the learning environment, and how is that correlating with absenteeism, and be able to report that data back out. So again, like I mentioned, the point of the whole survey and the point of the gating metrics on absenteeism is to see if the school is at a certain percentage above their normal baseline, however they define normal, based on the previous school year. In getting some feedback from superintendents, we did hear, well, for my school district, a 10% student absenteeism is completely normal. And other school districts were like, we're at like a 5% student absenteeism is completely normal. So we didn't try to define what is normal. It's just what percentage above your normal are you. So then, so that's it on the school absenteeism. I just wanted to mention a few things in closing. I will hurry. So for all of the metrics that I presented, it's just really important to know a couple of things. Data is always coming in. So that trend in incidence rate that I showed you, it's based on symptom onset date. So many times we have to wait for a local health department to interview a case and get that information. And then when it comes in, we backfill into the right week. Similarly, our percent positive is based on the laboratory test date. If a lab is delayed in getting results to us, which normally doesn't happen because we normally get lab results into us electronically, but if there is some kind of delay, then when we get that data, it's backfilled into the correct week. So the point being, it might be more stable to look a few weeks back to see what's happening trend-wise. And again, as in my conversations with the physicians that develop the metrics, I think it makes most sense to maybe not kind of focus in on just a 2-week period to figure out what your next decision is, but to look at what the overall trend is. And that's why we've provided data week to week, so you can see, all right, what's happening in that overall trend and make an educated decision as to where that trend is likely to go next. Similarly, we get the question, well, do you weigh one metric more important than another? No, we didn't weigh one metric more important than another necessarily. I think they're meant to be taken as a whole with other local knowledge about the situation in the community to help make decisions. So that's all I had.
Hi, I'm Dr. Amy Seary. I am a pediatrician who's a hospitalist as well as clinic and newborn coverage associated with Ascension Via Christi here in Wichita. We really do want to be respectful of your guys' opportunity to ask questions, so I'm probably going to go pretty quick through these final slides. I won't necessarily hit every point. I believe you guys do have access to the file now, which will help, but I do want to hit some points of emphasis that might preclude some questions you have coming up. This slide in particular is actually the third portion of the gating criteria that was formed in collaboration with our group and KDSE. What we want you to know from this slide is that there are some ways of creative thinking of how you can help reduce transmission risks in your own environments. We do recommend, per CDC, AAP guidelines and recommendations, that you do try to limit class size to less than 15, though we certainly recognize that can be a huge burden and difficult to accomplish. There is likely to be a reduced population because of remote learning options and alternatives that other families are choosing. If you can't get below 15, what you can do is try to at least maintain a cohort separately within the same physical classroom. So for example, if you have 20 students, you might try to consolidate 10 students on one side and 10 students on the other side of the room and discourage mixing during any periods between those two groups. You can also get pretty creative with the physical spaces that may or may not be in use, whether that be open school buildings, such as if the pre-K through 5 ages are doing in-person, but middle school and high school are remote, those spaces may be available for use to you, as well as getting creative again within the community of restaurants, churches, other gymnasiums that might be available. But everyone's going to need to be flexible, and I certainly can understand a logistical nightmare of moving beyond your traditional spaces. Next slide. So we really want you to have in mindset when you're looking at this gating criteria that we came up with these for good reasons. We really spend a lot of time going through the available data, that we don't want you to necessarily go around changing things unless you really want to go back to the raw data and spend the enormous amount of time that we've had to really understand this, to realize where we are compared to other comparable counties, cities, states, etc. That it's also not necessarily a good topic to hash out during a Board of Education meeting, that maybe creating your own advisory group would be the best way to sit down, really understand comprehensively what the numbers mean and what would be the best decision for your community. Next slide. So when we created this, we were actually already quite lenient. Our group is very passionate about getting kids back into school while still prioritizing safety. So we have already built in some leniency, and we really want to make sure that, again, if you get tempted to go changing things, that you really may be setting yourself up for a pretty hard, fast failure. We wanted something that allowed you to make a decision and move forward. If you can follow the gating criteria as recommended, there's a better chance that you'll get started and be able to continue on with what you wanted. And maybe even if your community rates decrease, that you could drop down a level. However, if you fudge the recommendations, you may be setting yourself up for failure because you'll put yourself in a situation that's untenable and will likely have to go to an elevated risk setting very quickly. Next slide. Please understand, again, based on the information that we presented earlier, that there is a distinction between our pre-K through 5th grade students versus 6th through 12th. It is actually a little safer to have that pre-K through 5 age group together, even during periods of higher community transmission. They are not as known to be as likely super spreaders, so it's safer for them to be amongst themselves, as well as for the adults that will be working with them. So there are times, for example, when you might be in the orange category where it seems like it's saying remote only, but if you look at the very top, it is stressing you have the option for in-person or hybrid for pre-K through 5, while you would be remote only for 6th through 12th grade. We really want to, we'll go to the next slide, focus on the fact that elementary students really have high needs of getting that foundation of how to learn, how to have good, safe social interactions, and having them do remote only is usually not nearly so effective. So we really want to prioritize their needs. That means, again, our communities have to pull together. We've known for months now what are the mitigation measures that work. For countries that have buckled down and applied these appropriately, they have school opening success. If you continue to be in a community, though, that doesn't follow these as stringently, continues to have high prevalence of this disease within their community, you're setting your school up for failure. And I think that we need to push that harder into public knowledge so they understand that when they make exceptions for themselves constantly, there are consequences for their school around them. Next slide. Speaking of school activities, I know that this is a very hot button, hot topic for everyone. So if your gating criteria shows that it's not safe to have on-site education, we really need to make sure that our extracurricular activities aren't preventing us from future academic success. So those activities should be very creatively modified with safety as that priority. We really do want, as pediatricians, that engagement that you get, all the benefits of those extracurricular activities, but not sacrificing your community's health or the education components of school as well. There are high risk and low risk activities. Low risk can definitely still be encouraged. When you get to high risk, we're talking about people who are having contact sports, who are having forceful exhalations in each other's faces for prolonged periods. There are reasons they are ranked as high risk, and that needs to be strongly considered. So we want to make sure that if you are implementing a path for extracurricular activities, that you do it as safely as possible, and also strongly consider that maybe you need to create a bubble for your school's teams for competitions and limit the amount of other district or outside of county play that might occur. Next slide. So in summary, there is a lot of information that goes into this. We're not trying to overwhelm you. We really do want you to make good, smart, informed decisions. You're going to have to be flexible with this. You can't just pick where you are and decide that's in stone for the next 9 weeks. It's a very rapidly evolving situation, and a lot of things can change in your community. So having that advisory team can help you really constantly stay up to date of what's your current situation. And finally, again, we are very passionate. We have dedicated our careers to the health, well-being of children. We really do want them to succeed. We really do want them in person. We love all those benefits that come from that, but we're also going to prioritize their safety, and we hope that you would as well. Thank you so much for letting us present today. And I believe we're open now for questions.
Yeah. Thank you so much, doctors. We do have a couple of questions, and Dr. Ahmed has answered some of those. But I would like to make sure that everybody is seeing that. From one of our superintendents, the question was, has the Department of Health and Environment, or KSDE, have they been training each county health department on this gating criteria? And Dr. Ahmed did answer that question, as she also answered another question based upon attendance data, mask usage, and information. So Dr. Ahmed, I'll put you on the spot. Could you answer that verbally to make sure everybody is seeing that?
Sure. As far as the gating metrics and the data on the dashboard that support the gating metrics, we have presented that data to the local health departments. KDHE has a call every afternoon with just local health departments. We've talked about it multiple times. We'll talk about it again today. I think so that's one thing. My plan is also to actually go ahead and record a training and put it online so that you don't have to do this over and over and over again. And we do still get a lot of questions about how to interpret it. So hopefully that will help. Then there's a question about where we're going to get the information on absenteeism and mask usage and the learning environment. So that is a Qualtrics survey that KDHE developed. KSDE did, Kansas Board of Education did send that out to all public and private schools. I have heard from a number of schools that they haven't seen it. So I've included the letter here in the group chat. So if this group can also help disseminate, that would be really appreciated. So it's a letter from Dr. Norman and myself, and then within the letter is the link to the actual survey is in there. So just every Friday, close of business, they just go to that link and upload the information per school building. We have had a few people that just reported for their entire school district, and we'll have to go back and ask them to break it down by different schools.
We do have another question that has not been answered yet. Studies have shown that all masks are not creations. This person do not seem to specify the type of mask. Can anybody clarify that would know that answer?
So I totally agree. All masks are not created equal, and there have been lots of studies out there regarding this. We recommend that masks have at least 2 layers. They fit snugly across the bridge of the nose and the cheeks, and there's not a lot of room for airflow because that is how aerosolized particles get out. I think that the reason that there's not been a strong recommendation for one type of mask over another is just the limited PPE that has been available. Some mask is better than nothing, and so trying not to exhaust demand for one specific type, I think, is probably the reason that there's not been one recommended. But that data is readily available, and there are certain fabrics that offer the electrostatic filtration, like silk is actually a very good fabric for masks. And so certainly if you want that knowledge personally, you can find that pretty easily on the internet. I will add in a comment about face shields. Face shields are not nearly as effective as masks, and a lot of states have actually said face shields do not count as face coverings. That is because there's gaps around those face shields, and those aerosolized particles can move out very readily. So face shields should not be used in place of cloth masks or surgical masks unless you're in a situation where that's the only covering that's available because you've got a child that is unable to cooperate wearing a mask or needs to be able to visualize the mouth for learning purposes.
Thank you,
It
Dr.
can definitely be used as an adjunct with the cloth mask. Sorry.
I've got a couple questions here that deal with college towns. So the first is, because gating criteria is based off of positive cases reported, counties like Douglas County with KU, who's doing widespread testing, is there going to be accounting for the sort of the massive amounts of negative tests, whereas in other counties there's only testing for those that are showing symptoms? Is there any accounting for that in the metrics?
That's a really good question, and so that's something to understand about the percent positivity, right? So because that denominator is positive and negative tests, if you do have an area, a county, for example, that is doing a lot of asymptomatic testing, then that denominator, you're not going to have numbers in that numerator, but your denominator is getting bigger and bigger, and so it does artificially make your percent positivity look smaller. No, there is not any kind of an adjustment for that. It is what it is.
Thank you. We have another question here from Mary. Do you see in the near future the capacity for increased testing availability and or shorter turnaround time on test results?
That's a really good question, and that's something that we across the state have struggled with, right? In the beginning, it was not enough reference labs doing testing, so really long turnaround times because everyone's sending it to LabCorp and Quest. We do have quite a bit more capacity now in the state. There are a number of local labs that keep saying, like, we've got capacity, send us the testing. So it is a matter of being a little bit more flexible. So we've been talking about at the state, how can we make schools and facilities, nursing homes, everybody more flexible? So maybe you're used to sending everything to LabCorp, but if you're getting terrible turnaround times, can you pivot and send to a MOD or a CRL or another lab that's got better turnaround time? So we are working on that. It's not for a lack of capacity, it's more a lack of people knowing or having the ability to pivot and go to a different lab.
Thank you, Doctor. From this next question, it appears that it's mandatory for those of you in healthcare for some sort of eye protection, but it doesn't seem to be discussed much in the educational setting. Is there a response to that?
I will speak to that. Carrie Harris, I'm sorry to introduce myself earlier. So certainly in an inpatient setting, eye protection is mandatory. In the outpatient setting, it's actually not mandatory. And I think we equate the school setting more similarly to an outpatient setting. It's only going to protect you more to wear eye protection. And that's where I say if you want a face shield or goggles as an adjunct to the mask that you're wearing, that's fine. The transmission can happen ocularly, but it is not nearly as common as respiratory transmission.
Thank you. Another question here that's going to be another good question, probably hard to answer, but is it reasonable and valid to attempt to evaluate these metrics specific to an individual district and make decisions specific to their district? Or is the interaction of people in and out of that district too varied and uncontrolled?
I think that's a really good question. The question is also a similar question has come up as to why we don't show the data broken down by zip codes, for example. And it's the same kind of concept. We are mobile people. People move from zip code to zip code. So right now we feel like it would be less useful and less, it's not going to get at what you're trying to get at, which is what is happening to my school population because we're such a mobile society.
Stephanie Coleman, I was going to tag on that if you don't mind. We're having that discussion in our local district too, and I think that that's where we put in the metric of the absenteeism, because once schools are open, that's going to be more of a kind of real time what's happening in our own local school buildings. We hope to kind of get gauge of transmission based in the local districts.
Thank you. I believe this next question probably goes back to our last two answers, but this particular board member is districts partially in the southern part of a larger, more suburban county and the northern part of a more rural county. The spread is widely different in those two counties. Any suggestions on how they reconcile that data?
So I'm in Andover School District, which sits on Butler County and Sedgwick County. So we're kind of in a similar situation as this. We're looking at kind of 50% from each county, since about half the population lives in one county and half the population, the district population, lives in the other county. So I don't know, Dr. Ahmed, you may have some thoughts on that too.
Right, I was going to suggest something similar, which is if you know your population kind of straddles counties, maybe look at the data from both counties and kind of consider, you know, what is happening with the trend in the two counties together.
Thank you. The next question is maybe very similar to what your response was to the college counties, but this particular board member is in Sedgwick County with large clusters in their jails and care homes. Is there information available to those metrics that excludes those groups?
The Sedgwick County Health Department actually on their local tracking board excludes correctional facilities and long-term care facilities, just to account for some of those clustered outbreaks.
Sam or Britton, have you seen any other questions that I have missed to make sure that everybody has an opportunity?
What about, Dr. Kuhlman, what about contact information, or if board members or districts have questions moving forward, what would be the appropriate process, or how would you like us to handle that if they have questions that are really probably more for medical experts?
Sure. We have an email account. You're welcome to email us. It's Kansas COVID Work Group 4, the number 4 kids, and I can type that on here too so you guys have it. So Kansas COVID Work Group 4 kids at gmail.com. Or if you want to get questions to Gary or Britton, I'm happy to do any questions that way too.
It does look like we have a couple more questions that have come in, so we do have a little time. So question from one of the far corners of our state: will rapid testing equipment become more readily available to more rural areas sooner than later? The lab work turnaround seems to be detrimental to some of the decisions being made.
Right. So I can speak to kind of at the state perspective, you know, for several months, it's been a manufacturing slowdown. So for example, we knew that the Abbotts weren't being manufactured and therefore you couldn't buy one. That seems to have loosened up a little, but there's still a lack of the actual kits that you need to run on the machines. So whereas we are seeing some shaking loose of being able to buy the instrumentation, there's still going to be a shortage of the kits to run those instrumentations. For example, the federal government has essentially said that they will send a rapid testing machine to every nursing home in every state. And that promise was made over a month ago, and as of right now, I don't think any of our nursing homes in Kansas have gotten them. They're supposed to, but you know, it's hard to get that much instrumentation out.
Thank you. Dr. Harris, you answered a question online on our chat, but the question was, How would small districts handle the gating metrics? One positive case in a low populated county can definitely change their data. And you did have a response, but if you would like to verbally explain that.
I think we talked about that. I just also wanted to point out that if you have staff traveling to and from the county that's more affected in that situation, you're going to want to probably take that county's rates more into account than you maybe would even if most of the students are coming from the rural part of the county.
Very good. I think Dr. Hard has answered the question, but we did put this particular PowerPoint in the chat so that you can download that if you so choose. We do have a recording of this, so if you'd like to include or like to be able to listen to the conversation, that will be available to you through the member portal. Sam, it looks like we have 4 new questions. Have you had a chance to look through those, or maybe we're at the bottom?
I think we're pretty well at the bottom, but as always, if people have more questions, feel free to contact me, Gary, or Britton, or at the email address posted by Dr. Coleman, and we'll be happy to direct those questions to where they need to go.
We do have one last question, so I want to make sure that we give everybody equal opportunity. Sam, thank you for those words. I'll say, make sure you ask Sam with a smile on my face. Let's see, I think we had a question and I don't want to make sure I miss it. Looks like it's been answered by Dr. Ahmed, so thank you. We appreciate that. I would like to really thank this group because they really have no motive but to do the right thing for boards of education, students, staff, and communities. So thank you, Dr. Kuhlman. I know I've been going through you, so thank you for getting all of these doctors on board. I think our group here has greatly benefited from the knowledge here. So with that said, I want you to be aware that we do have another session and we will already have it planned. We have two couple of groups that are going to visit with you about sanitation practices, things they have learned through the COVID crisis on how to sanitize schools, places that you need to be especially aware of. I wanted also to make sure those of you that are board presidents, vice presidents, that you be aware we have an on-demand video series for you to be able to watch at your own time, and we will provide some online forum to discuss those at a later time. So please see our KASB website if you have interest in that. With that said, once again, doctors, thank you. Thank you so much for spending your time with us. And this will be the conclusion of this meeting.